Continuing on with this first question. So the vital signs are normal. Examination shows no abnormalities. Studies show CD4. Oh, let me let her in. Yeah, I think we'll do the meeting info. Give me 1 second. So I can turn off
Yeah,
the.
sorry.
No, you're good.
No, you're good.
Oh, meeting security. That's where I have to go. Hide, waiting room, lock meeting. I don't know why. Oh, here. That's where I need to go. Play sound, and then I can also disable the waiting room. Okay. Now that we're back to our regular scheduled activities, you didn't miss much, Yui. Honestly, we just started this first question. We were just talking for a bit. Basically, it's a guy, he's up to date on his vaccinations. He's HIV positive. He's compliant with his antiretrovirals. And his CD4 currently is 643. He's above the normal range and no viral load detected, which is really great to hear. So at this time, which is the most appropriate, I'll just open the polling so that we can do it without confusion. Okay, we have everyone answered. Let's see what's going on. Okay, since it's my first question, after that, I think Bianca and then Yui can go in terms of roundtable wise. So we were torn here between two things. We said either no vaccinations or we go with the inactivated influenza. So those are the two that we came down to. He doesn't need a HPV at this point because he's up to date, and typically that's not reserved for folks. They typically do that in childhood, right? Especially for males.
Like 9 to 26, right?
Correct. And it's like younger males, like in their pediatrics years is when they typically get that. Measles, MMR, so he's covered for that. He probably already got his meningococcal in order to go to school. I don't think rabies is appropriate at this point, so that's not there. So we were torn between influenza or no vaccination. I personally went with influenza because influenza is an annual vaccination, right? So no matter what, we give it regardless of immune status, because it's an inactivated influenza virus. He doesn't, have anything that would stop it. And that's the right answer. I personally didn't know if we needed to go no vaccination because he can still receive one vaccination, right? And that's what the NBMEs as well said here. They said patients with HIV can safely receive inactivated influenza vaccine. So that's one of the reasons why I just went with influenza.
Wait, can you repeat what you just said? Sorry. The NBME said what?
the NBME said that it's completely fine for them to receive an inactivated influenza vaccine, because influenza is an annual vaccine, it's an inactivated type. So it's completely fine versus let's say if it's an activated vaccine or like a live vaccine, then we'd be like a little bit concerned that they might not have the right immunity to battle anything that's
Right.
given as a vaccine. So it's not a problem here.
Okay.
All righty.
You guys can go ahead. Give me a second. I'll be right back.
Okay.
Yeah.
Okay, do we wait or should I just like go over the question?
You can go over the question if you'd like.
Okay, so which of the following age-related changes is most likely the explanation for the findings in this patient? Okay, so we have a 92-year-old female brought into the emergency department 30 minutes after being found confused in her home. The weather has been extremely hot and the temperature in her room is 90. Oh, that felt cool. Okay. Multi-infarct vascular dementia, and MI 30 years ago. Stuporous, temperature is high, pulse is high. Respirations are fine, blood pressure is very low, dry mucous membranes, no JVD, clear in oscillation, grade 2 out of 6 holosystolic murmur at the lower left sternal border. The remainder of the examination shows no abnormalities. Test of the stool occult blood is negative, so which age-related changes?
Take your time. We don't need to like punch to an answer right away.
Yeah. So I am stuck between D or H.
Okay.
I was thinking like it might be a thyroid issue.
Mm-hmm.
I don't think the thyroid really has anything to do with you being cooled down, really. It's more,
No.
yeah.
If anything, you would have like hyperthyroidism, and that would cause you to like be more prone to like being heat affected. But that we're talking about like someone who's like severely thyroid level compromised. I don't think I haven't seen it in older people where like they typically have a thyroid issue that leads to them having a heat stroke.
Yeah, like this is for sure a heat stroke. So it
Yeah.
might be like she's not able to like drink or anything like that. So I might say like H would be the right answer, impaired thirst. Every
Yeah.
other option here doesn't really pertain to why she's very overheated.
Yeah.
And she's clearly dehydrated, so.
Okay.
Okay.
So why did you also rule out renal salt wasting?
Oh, yeah.
But remember, I'm not trying to sway your thought process. You have the right thought process. Why would you rule out J? Because I will say you are correct. Because like this
Okay.
this is right. But why is it not renal salt wasting?
Trying to remember. Because of like the vascular issues in the brain, huh? But the thing here, like I would think Renal salt wasting. Oh.
So I was, when I initially looked at this question, I
Mhm.
kind of wanted to pick J
Mhm.
because I was like, oh, like people that are older, their GFR is different, right? Like it's
Right.
decreased. With age, like renal function decreases, but
But I don't think they will have
GFR,
like renal salt wasting like that.
exactly, GFR is different than salt wasting, right? Your
Mhm.
decreased GFR in older people is not associated with like you not having the ability to concentrate your blood, or like, sorry, dilute your blood and maintain appropriate like hemodynamic levels.
Mhm, mhm.
So that's not what they're saying there. That's why I wanted to help, like, just in case if that thought process came about, just to
Mhm.
rule that out, because the other ones don't really make too much sense, like, except for like the thyroid thing, which you're right. You can either be like the hyper or hypothyroidism that could predispose you to being like either cold intolerance or the heat intolerance, right?
Yeah. Mhm.
But typically for her demographics, age related thyroid issue is not an age related issue. It tends to
Yeah,
be either like an
exactly.
endocrine issue.
Hmm.
Okay. Yui, I hope we were able to jump in at the right time and hear like the pertinence and make your life a little easier.
Yeah, I'm still trying to. I have this really bad migraine, and so like my vision kind of gets kind of weird. So that's why I had to like get medication. So just bear with me.
No worries. You and Bianca are struggling today. No worries at all, guys.
Yeah,
Just
and
please,
I'm so
please.
mad
I
at
know
just
it's stressful times, so I don't want you guys to be dampening your guys' health in the process. I have like a cough. I know that's nothing compared to your guys' headache, but like I can see like the lack of sleep and my immune system like struggling to keep up with
Mhm.
this thing. So I literally like had like 3 halls in the afternoon and I was like, oh boy,
wow.
it's
Wait, so
happening.
I'm
But
confused with. I'm so sorry. I'm confused with what's
yeah,
happening.
Mhm.
so
Uh,
this is a heat stroke, right?
Mhm.
You can make that diagnosis fairly quickly, but the thing that they're asking is what age related thing that would impair this person from living their best life. And the thing that I kind of narrowed it down and what Bianca narrowed it down nicely was that it could either be a thyroid issue. I said it could also be a salt issue. And the correct answer is like the impaired thirst, right? But we both got to the right answer, but I was keeping the differentials appropriate. The important thing we wanted to kind of address is that thyroid is not an age-related thing. As you age, yes, your thyroid doesn't function as optimally, but you don't have extreme fluctuations, right? You don't either have hyper or hypo. You typically just have like a just decreased function in general.
okay.
So that's not that wouldn't happen here, right? Based off of age, all right? Because she's having a severe response. Now, the salt wasting is a different term to decrease GFR, right?
Mhm.
GFR, as you know, when we get older, GFR drops. But salt wasting, you don't lose that ability, right? Like you can still constant or dilute your blood and maintain blood pressures appropriately. What they mean by salt wasting is that it's like an adrenal issue or a RAS system issue that's leading to this, which is not what's being seen here. That's not an age-related issue. That's a problem. That's a medical problem.
Mhm.
So the best thing is that, you know, at the neuronal level, at the brain level, like they just have a decreased thirst function. So that's the best you can kind of do, because age-wise, everything kind of just downward spirals.
Mhm.
Okay, that makes sense.
Does that help? I hope that
No, yeah,
I
it
try to be
does.
succinct.
No. I was just trying to understand what the question was asking and stuff. But okay, yeah, I do. I do.
Let's do this one. I'll keep the same thing since you guys didn't click into the other one, and we can just time it like that.
Okay.
Let's do a minute 10. Is that okay?
Yeah.
Yeah.
Okay.
Okay, you repull it because I exited it off.
All right, that's minute 10. Let's end it. So what did you guys think? I think this is Yui's question.
Oh. Um, so I was thinking, do I have to read the question or just go ahead?
Yeah, you can go ahead. Whatever you prefer.
Okay. I'm sure you guys read the question. So,
Yeah,
um,
I'll
I
just
was
highlight the
thinking,
pertinence.
yeah, so like the fever, does have SLE and she had a Neisseria meningitis 3 years ago. She's being treated for the SLE with the hydroclox, whatever that is. And then she had the fever, nuchal rigidity. So pretty much she has another meningitis and it's due to a gram-negative diplococci. So I'm assuming it's another Neisseria meningitis
Yeah.
issue.
Yeah.
So it looks like, this is like another type of Neisseria happening infection. So I would be thinking some type of complement issue, like the MAC deficiency thing.
Yeah, so this is a nice one because it's like they gave you like gram-negative diplococci, which is just like
Yeah.
right off the bat, is like Neisseria, but like they could have also given us like a gram-positive lancet shaped, and that would have worked too because that is also encapsulated. And the problem with this is that anything that's like I think encapsulated is can't be fought off with a MAC deficiency, which is what we're saying is B.
Mhm.
Wait, so
That-
are you saying like if it was, let's say the gram stain, like you said, was gram-positive blue-cocci, when I think of that, I think of like strep pneumo. So if it was strep pneumo, would you still think it's complement though? I thought like,
It's not complement if it's strep pneumo.
yeah, I don't think so
I thought
either.
it's you can still have MAC level stuff because of the
Because like if it's like
it's
MAC,
encapsulated.
true, but like I thought like with recurrent like Neisseria like infections, those ones are more predisposed to like a
Specific,
MAC issue.
yeah, the MAC.
Oh, okay.
I
So
think
it's just a
that,
predisposition, but
Mhm.
I don't know, because like I remember something that if they're like affected with like most encapsulated things, but that could be also from like asplenia
That's
Yeah.
for someone with like sickle cell.
Like a
Mhm.
spleen thing, yeah, I think that's more.
That's more pertinent. Okay,
Yeah.
thanks, guys.
Oh, and then with sickle cell, that one's more like salmonella issues, I think.
Yeah,
That's for the osteomyelitis. For the sickle cell, right?
Mhm, mhm.
But I think you can get infections. I think you like what Kishore was saying, I think you can get like encapsulated issue.
organisms.
Yeah, because of the spleen. You have a
Yeah,
splenomegaly, whatever they call it.
Yeah, splenectomy, like
Yeah.
autosplenectomy.
So
Okay.
you're more prone to more encapsulated infections.
Yeah. So it's a lysis of bacteria, especially gram-negative bacteria, by perforating through their cell wall. So Neisseria would be our best bet for something like that. Cool. Thanks, guys, for helping me clarify my thought process. Don't want to get this wrong. Sweep hole. Okay. We were a little mixed on this. So what did you guys think this was? Oh, actually, this is my question. I can't. Let me try not to do that. Okay. So which of the following is the most appropriate next step in the management? So this is a young gentleman with a 10-day history of fever, sore throat, and generalized fatigue, right? He has like multiple sexual partners, does not use condom consistently, is not an IV drug user. Everything like vitals wise is okay. He's a little warm, but he's not running a fever currently. He's just 100. There are numerous erythematous macules in his upper chest, multiple less than 1 centimeter cervical and occipital and axillary lymphadenopathy, and 1 centimeter tender oral ulcer without exudate or thrush. The throat is injected, which just means there's some kind of lymphatic issue as well as vascular. Okay, so abnormality, monospot and rapid strep is negative, so you wouldn't do another throat culture, which is the following is the most appropriate. Okay, so we said between A, D, and I put A, so measurement of HIV viral load. So the reason why that we're going to go with that specifically is due to the fact that he has his history is more consistent with the fact that we have to check this because he has multiple presentations of not only just like maybe HSV, he could also have some kind of oral manifestation as well as he has painless lymphadenopathy, right? So those are all more indicative for a HIV test as compared to going directly to maybe going with acyclovir.
Yeah, I was even thinking like when I saw like the monospot and like the rapid strep, I was like, okay, it might be CMV, but CMV wouldn't show like this type of presentation. I would understand like the oral ulcers, but like all of this, the whole thing, especially with his like sexual activity, of course, like testing, I was like, we need to do either some type of like testing for any viruses before starting any therapy.
I have a question though. Where does it say that he has painless lymphadenopathy?
Multiple.
So less than 1 centimeter. So technically, yeah, he has a lot of like lymphadenopathy, but it's not showing any pain, right? Like they didn't mention it as a positive. So I might have read into it, so I apologize.
Okay. I think, yeah, the only thing that I'm like reason why I'm like, okay, yeah, it might be HIV was I remember studying with HIV, you would have the macules over your chest. I don't know if you have that with herpes. I don't think so.
No, not with herpes.
But I know you do have that on the upper chest with the HIV.
So this is just it's also I think like it's a procedural like an algorithm based thing. Like whenever you're looking at this, like often you have to end up thinking about what are the 3 basic things that we're always going to order. We're going to order HIV for someone who's like recently started sexual history, right? Like HIV, chlamydia, and then gonorrhea. So those 3 you're going to order no matter what, because they will inform if there's an underlying problem, as well as if there is an ongoing problem that isn't being captured through a health screening test, right? So I initially thought it was just herpes simplex virus because like herpes simplex presents like this, that you can have erythematous macules like everywhere, right? But you can't jump to that and start giving them acyclovir until you can confirm it. And to confirm it, you first want to do HIV, and then you would want to do a herpes simplex just to make sure there's no underlying problem. So like it's a stepwise function.
It's like, it's weird because like even in the clinic, they just order all of these all at once. They don't do like the stepwise thing.
Yeah.
So it's like tough to figure out which one is like the most immediate thing that you should be doing.
Absolutely. Because it's like one order for them. It's like, it's literally like STI screening.
Mhm.
And that's it. And it covers everything. It covers HIV, it covers HSV, it covers, chlamydia, gonorrhea. And if you suspect something more, then you like get more specific with your STI screening. But most of the times, like if you capture those three, you're tend to cover up most of your sexual health bases.
Mhm. Mhm.
Okay.
Right.
Don't get dejected by this, because this is the hardest and one of the harder NBMEs. So that's all I'm gonna say.
Okay.
I'm there with you guys. Take it away, Bianca.
Okay, I forgot I muted myself. Okay, so this one's just asking about the most likely diagnosis. So we have like an asymptomatic 67-year-old man for coming in for like a routine examination. He's been healthy pretty much. It's just showing like mild splenomegaly, and then we have his lab values. His leukocyte count is extremely high. And then it has like the segmented neutrophils, bands, eosinophils, basophils. His platelets are very high. So this looks like a presentation of possibly like a CML. So I just chose B.
Awesome. Any other ones you guys want to discuss, or you guys are good?
What is C?
What is C?
Yeah. I just
Myelomonocytic.
I think you would have an increase in the monocytes too. I think it's one of the yeah, one of them. There's like similar, but you
Is
would
it
have
like a subtype? Like, I never heard of this one.
It's a CMML. It's a subtype. It's also a myeloproliferative condition. I'm reading this out, by the way. This is not something from my own brain. It presents with increased peripheral monocyte count, myelocytes and monocytes are both derived from undifferentiated multipotent stem cells. They are distinctly different different cell lines. The patient's peripheral smear does not show increased circulating concentration of monocytes. So this is a myelomono thing. So like you'd have to look at myelocytes as well as monocytes to see if they're like hella elevated, and you don't see that here.
Yeah, okay.
So it's another myeloproliferative disorder, like similar to CML, right? So
Okay. I was like wondering, is that another subtype? I've never seen this one before.
yeah. If there's no questions, we can move right along to the next one.
Sorry, sucks like when you can't have the lab values in front of you.
I apologize for that because like if I threw that on the screen also, it's gonna be such a struggle to
No,
keep
no,
it all
no, it's not
together.
you. No, 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 not you.
But yeah, take your guys' time. Like if you guys need to look at lab values, like I eyeball the lab values all the time. So sometimes I get it wrong just because I like eyeball it wrong. So it's smarter to go through it.
Okay, let me just.
Okay, that covers it. So what is this, Yui? I think this is your question.
Oh, mine, sorry. Pretty much this woman has rheumatoid arthritis and
Mhm.
showing symptoms of it. And so, it's a chronic issue, so you would have anemia of chronic disease.
Yeah,
So normally with anemia of chronic disease, you would treat the underlying issue. So in regards to the anemia, you don't really do anything specifically for the anemia. However, you would try to treat the rheumatoid arthritis.
perfect. So no treatment at this time. That makes sense because like, no matter even if you gave like more iron, it's not going to
Mhm.
solve it. It's just going to sequester it more, right? Hepcidin would
Mhm.
be elevated so high that it wouldn't have any effect. Erythropoietin is typically given for CKD, transfusion of packed red blood cells. What's the criteria for transfusion?
When the hemoglobin drops to 7%.
Yeah.
Yeah, less than 7, you transfuse it like nobody's business. Colonoscopy, no, because we don't suspect an active bleed and we don't like to give colonoscopies for everyone. Bone marrow biopsy, not really indicated here because it's not something that we think is at the bone marrow level, a hematological level. It's more so due to the chronic inflammatory responses.
Mhm.
Nicely done. Let's do the next one. I hope I didn't explain that too much, just so that I like to make sure, we cover any sort of like extraneous concepts that might be like here.
So the oral iron therapy, you only give that if they are iron deficient?
Mhm.
Yeah.
Only,
Yeah.
okay.
Yeah, I was so tempted to put A, but like, because like in practice, in medicine, I've seen people with chronic disease have iron
Um,
tablets prescribed to them, but according to our NBME friends, it's kind of a pointless fight that you're
it doesn't
fighting.
hurt,
So
right? I don't think it hurts to give iron.
yeah, but apparently, hepcidin's elevated, so no matter how much iron you give, it's not going to be absorbed as much through the GI system. Okay, let's punch it in. Okay. Let's see. So,
Honestly, I wasn't too sure about this answer. I didn't want to take too long though.
well, what's up?
I wasn't sure about this one, but I didn't want to take too long, so I kind of just picked an answer.
No worries, no worries. So this is a elderly gentlewoman, sorry. I was gonna say gentleman. Decreased hemoglobin concentration. She had a hemicolectomy 10 days ago for a GI bleed secondary to diverticulosis. She had 4 packed units put in her, hypertension and type 2 diabetes, including lisinopril and metformin. She's a little warm, but she's not febrile, blood pressure is okay. She has mucosal pallor and conjunctival injection. Conjunctival icterus, my bad. She has a well-healed scar, hemoglobin concentration post-op baseline on day 3 was a 10. Hemoglobin today is 7.5. So it's a slow trickle that's causing her hemoglobin concentration to drop. So we were torn between 2 things. And I'm going to highlight both just so that we can get this in there. So we were torn between that and that. Okay. So based off of this, let's kind of work through it. So why is it not negative and increased direct?
I said increased indirect because of it's just like a very acute loss of blood. So I was thinking it was just not going to be conjugated quite yet. So
Yeah.
I just put indirect. So that narrowed it down to 2 choices. And then I literally had to reread the stem again because I was like, then what's the cause of it? And like you said, it's like a delayed reaction. So I was thinking it might be like some type of delayed blood transfusion reaction that might have caused this.
Yeah.
So from what I remember, that one had like a Coombs test of being positive, I believe. So that's why I chose E.
Great. So that's a perfect way to kind of work through the thought process of what's happening here, because these aren't necessarily a hard question, but the problem is that you needed to know that this is something that's happening in her vasculature, and it's something that she can't that is responding to this like later on, like right away. If she was transfused, let's say it's like an ABO incompatibility, she would have a reaction right off the bat, right? So your lab values would show appropriately different changes. Here, it's a minor group, maybe like an RH factor, maybe a factor that they can't identify. That's always going to come with a Coombs positive test, like Bianca said. And indirect, because it's hemolysis, regardless of how you put it, is going to be elevated. Indirect would be elevated because you're overloading your liver from clearing out any of the indirect bilirubin that's made. Does that work for everyone? Any questions? Any other ones that like we can work through? Because the only thing I think that separated B from E was just the Coombs. So you just had to remember that Coombs would be positive.
Okay. So the Coombs would be positive because of the transfusion.
Yeah. So because it's a minor reaction, because she has hemolytic anemia. She just has hemolytic anemia due to a minor factor rather than a major factor. Okay. Because major tends to appear like right off the bat. Like, as soon as you put it in, they're gonna be like, "Oh, we're gonna start rejecting it."
So it was minor. That's why it was delayed.
Yeah. All right, let's do this one. And seconds, just punch in an answer. You guys
Oh,
can do
my bad. Sorry.
it. Trust your guts. You guys know this.
Mm.
Awesome. Take it away.
Oh, my turn?
Yep.
Oh, okay. 52-year-old man is brought to the ED. He had a 30-minute episode of weakness in the right arm and difficulty speaking, but his symptoms resolved. He hasn't been to the physician in 35 years. BP 160/96, and he has a diffuse point of maximal impulse and S4 gallop. He also has a Bruin femoral artery. Hemoglobin 9.7, glucose 156, creatinine 3.2, cholesterol 210, and he has left ventricular hypertrophy. So, I think if he treated the hypertension, would have avoided all this stuff.
Perfect. Beautiful. Let's look at the next one. I love questions like that. Makes me so happy. It's sad how little makes me happy nowadays.
Oh no. Oh, was there a poll? Sorry. My bad. I like answered on my iPad and forget to answer it on the.
Did you guys click in for this one?
Mm-hmm.
Okay. All right. So what does she have? This is my
Isn't there
question.
some type
So what's
of,
up?
some type of dementia?
But she's
Yeah,
32.
she's
Oh my-
92. She's 92. She's not bad. She's not doing bad at baseline.
Yeah.
Not gonna lie. Compared to her sister, like we have a lot to work off of here.
Mhm.
I didn't want to say a family history of dementia because she's actually doing well compared to her sister.
Yeah.
And her sister's only 90, right? The only thing that's problematic for her is that her brain functions are decreasing, right? Her thought process and that stuff is decreasing. So this is just age related. I wouldn't say dementia per se, cognitive decline.
Yeah.
Okay.
I was even thinking about it might be dementia, but I was like, okay, so her younger sister has significant memory issues, but like her younger brothers do not. And then it like from her physical examinations, it doesn't seem like it's that very Yeah, it's not that much. It's like something you expect a 92-year-old woman to have issues with.
Yeah.
Mhm.
Because a lot of the times, like everyone mentions what year it is annually. No one sits around mentioning to old people like, grandma, it's January. Like most of the times they remember the year. So if she's able to recall like recent holidays, that's what, when I was doing neuro, I found that that's a quick way to like catch if they are capable of like
Mhm.
recalling like details enough that it works for them. So
Mhm.
even if they can't answer the date or the month, it's okay if they can remember a holiday. And difficulty naming stuff, that's no problem. So she has good like ability to see names of the animal. That's fine. You know, if I was that old, I would have a hard time remembering that many animals. Okay. Um, recalls only one of the three items after 5 minutes. So her memory's not that great, but it's not too bad.
Mhm.
So I just put age. Okay. Let's stop that. Let's do the next one. This is this question. Do a minute 10. Five minutes on the clock, or sorry, 5 seconds. And we're punched in. Let's see. You, it's your question. Take it away.
Okay, 42-year-old man comes to the house because of severe right-sided headache for the past 3 weeks. He said that he awakens every night at 3 a.m. with a sharp stabbing pain behind the right eye and lasts about 30 minutes. There's no nausea. He smokes 2 packs of cigarettes daily for 25 years and drinks a 6-pack of beer daily. Vitals are normal. Exam shows ptosis on the right and tearing and conjunctival interjection. The right pupil is 2 and the left is 4, which is the following is the diagnosis. I thought cluster, mainly because of the tearing and the injection in the eye.
Yeah, same.
And if you see that together and plus like the ptosis, in ptosis you can get it with cluster too, and it usually is just one-sided. So that's totally fine.
Yeah, I never knew you can get ptosis with cluster though.
Yeah, I think you like even in first aid it was saying like you could like it's unilateral headache, typically like retroorbital or like in one side of the face, and you can have ptosis based off of that. That's like the one of the few things I remember. So
Because I almost
but
was
with
thinking, even though that wasn't an option here, but I was just
well,
like, is this some type of like cancer? Like you know how like
yeah,
Horner?
one-sided, you're thinking of Horner's.
Yeah.
Yeah, Horner syndrome. But they need like flushing of their face, like one-sided of their
Mhm.
face just turns warm, and they shouldn't be they would be anhidrosis, so they wouldn't be diaphoretic on one side of their face, like ptosis, anhidrosis, and one more thing. What's the other one?
Mydriasis?
Yeah, mydriasis. Wait,
Mhm.
ptosis, anhidrosis, mydriasis. Yeah, yes. Perfect.
Would it be mydriasis? Because
Oh, is it mydriasis or mitosis?
I think it'll be meiosis because the sympathetic is messed up. So then you would have right? For Horner's, the sympathetic is messed up. So you would have
Yes. So
meiosis.
you would have, okay, constriction. Okay.
Constriction, yeah,
Yeah.
constricted pupils. Y'all had me tripping up for a second. Okay, let's do this one. Got a nice derm level question. Is there a better one? Oh yeah, let's do this one.
No, I hate term.
I know, right? Okay. Let's see how we did. Okay, a little bit of a split. Whose question is this?
I don't remember. Is it you?
I just did mine. I just did it.
Oh, it's probably the shore.
Okay, fine. All right, so we're trying to find a historical factor that increases the patient's risk for developing this lesion. So we have a slightly older gentleman with a one year history of slowly growing kind of lesion, painless enlarging in his right inner thigh. He notices that the lesion only when he bathes. He believes he might have developed a similar one in his forearm. He has a HIV infection that's well managed. He takes daily multivitamins. He does not smoke or drink. He used illicit heroin 5 years ago, but stopped for 5 years, but stopped 35 years ago. Sorry. He worked on the farm for 40 years. Vitals are normal. Lesion is shown. And the right lesion, the right forearm lesion, is 3 centimeters, well raised, well demarcated with a good border. The remainder of the findings are normal. I personally put A because I thought this was sub-eric or whatever keratosis or whatever
Yeah.
that nonsense is.
Mhm.
Because it kind of looks like it's stuck on appearance. Although this is like a really bad picture because I kind of almost see an irregular border and I'm like, what's happening here? But
I
that
thought
tends
it
to be
was
like,
one of the. I thought it was the other, not
The actin one?
melanoma. Yeah, like one of those squamous or something, like not the melanoma, but the other ones.
Like,
Not basal either.
so squamous or
Yeah,
actin,
squamous.
keratosis, whatever
And
that was.
usually you get that if you're working under the sun, right? Like skin cancer.
But this was showing over his inner thigh. So I would think like it's not in contact with the sun that at all.
often, yeah.
Oh,
So that's why I even thought it was like the sun thing, but I was like, wait, it's in his inner thigh, so it's not really in direct sunlight. So I literally just guessed age for this one.
Yeah. I
Because
just thought it was an older dude and we kind of roll with it because like that usually gender doesn't affect this because old people, regardless of male or female, get it, right?
yeah, is male or female.
Yeah.
Yeah, and then the medical history, I don't think really like the heroin or like even HIV won't, it could cause like the like skin manifestations, but not like this. This is just like one that's just showed up randomly.
Yeah.
And
Oh.
yeah.
Let me ask you guys a tough question instead of this one. what happens if a patient has a bunch of these and they're like, let's say 45 years old in the trunk and the back region?
Isn't that
What are you
when
thinking?
the neurofibromatosis thing?
Good differential, but no.
Hmm. The front and the back.
Yeah.
Front and the back.
Yep.
Don't tell me. Hold up.
Wait, is this exact type of lesion like a seborrheic keratosis?
Yep.
Oh, it's not tuberous sclerosis, isn't it? No, that one's
Mm-mm.
different.
Mhm.
It looks different.
It
Yeah.
is very different, yeah. That had these trunks and
I feel like I did see this before. Hold on.
This is a tough one. I'm not gonna lie.
Hmm.
You guys want it?
Yeah, just tell me. I give up.
It's the lesser Trelot sign due to gastrointestinal malignancy.
Yeah, I wouldn't have gotten that.
But
I
when
wouldn't
you
have
said
gotten
that, I'm like, oh yeah, but wow, I wouldn't have gotten it.
Mm-mm, mm-mm.
So if you see a youngish patient and they have this plus lymphadenopathy, axillary and cervical lymphadenopathy, plus the lesser Trelot sign,
Mhm.
which is a bunch of these on their trunk and back, it's malignant. Like they got GI cancer, they got stomach cancer.
Okay.
Okay, let's do this one. That's a tough one. Don't worry, guys. I literally learned that from getting wrecked in Euro the other day. Okay. I think I did the last one, so this is Bianca's.
Mhm. Okay, so we have a 67-year-old woman that comes to the physician because of persistent actinic keratosis despite treatment with 5-FU. Examination shows a 0.5 to 0.5 centimeter lesion. And then the photo shown was the appropriate next step in management. I said excisional biopsy just to figure out what this is and actually just extract that whole thing out rather than doing like a punch biopsy or anything like that. Radiotherapy, not really. You don't even know what you're dealing with yet. And then systemic chemotherapy followed by surgical. I said, yeah, I would just go with the biopsy just to see what it is.
Beautiful. So excisional biopsy covers it because I think they reserve punch biopsy for like melanomas and stuff because they just need to get a section out and they don't need to get like the entire thing out. But don't quote me on that. Radiation, like you said, doesn't work. But excision will also like persistent actinic keratosis. I think it predisposes you to squamous cell, right?
Yeah.
Yeah, squamous cell.
Nicely done. Let's do the
Is
next
the
one.
punch biopsy the same thing as a depth biopsy? Like I know they're supposed
Yeah,
to do the staging by depth.
correct.
Okay.
Yeah. It will punch biopsy will like it goes through the full length and tells you like exactly like how far it's invaded through, especially like a melanoma.
Mhm.
You got to do that.
Yeah. Okay.
Yeah, I like this is why I like working with Bianca. She's triggering my memories from SGU, like random tidbit of information just like popping up in my head.
Mhm.
Love it. Okay, let's do this next one. What's the answer, guys?
I guessed.
Staph
You guys
aureus.
I
guessed.
said Staph aureus.
You guys guessed.
I guessed because I was like,
Oh.
I was thinking like it was like septic arthritis. And I was like, okay, it's not disseminated gonococcal. That showed it like a younger patient. So I was like, why is this 47? So I was like stuck between A and C, and then I just did rock, paper, scissors, and just for C.
I
Yeah.
honestly didn't read the full question.
she
I
she
thought,
she really just saw the leukocyte counts and she's like, Staph aureus.
yeah, I saw chronic
That's my
issue,
boy.
and then now he has
Yeah.
septic. He got an infection, and then the leukocyte. I was like, all right. Usually
So
stuff.
how do you know if it's septic, right? Like how would you know if it's septic versus reactive arthritis? This is
I
really
think
important to know.
wouldn't you have other symptoms too? Like,
True, but the thing with MDMEs, they might not give you everything, right? So that's always a problem. That's why I rather ask you guys
but I
these,
know
what
it's
you guys.
septic. It doesn't have to be greater than 50,000.
Yeah, exactly. That is the distinguishing factor. So if your segment, or sorry, if your neutrophil count is less than 50,000, but it's still elevated when you do the arthrocentesis, because you're gonna do it for both, right? You're gonna tap that joint. And the thing that's gonna tell you if it's an active ongoing infection is that threshold, right? Greater than 50,000, boom, you have septic arthritis, versus something that's more like, let's say it's 25,000, right? Or sorry, yeah, 25,000, then you would think maybe reactive, and it shows up after they had some kind of primary infection.
Mhm. When would it be Neisseria?
Neisseria, the young person, they have a mucopurulent discharge, and then they show up to the doctor's office and they were like, well, I just felt kind of bad and now my knees hurt. And you're like, well, let's check. And you'll find out that it stains positive for gram-negative diplococci.
Did you say that you said they were feeling bad before, like they were feeling sick?
Yeah, so they would get for example, guys or girls would get mucopurulent discharge. Okay. They would also have because Neisseria can affect the conjunctiva too. They can have conjunctivitis. They can have muscle aches and fatigue and all the fever signs and symptoms. But typically Neisseria, like let's say it's disseminated, one, it's going to be unilateral, right? It doesn't do bilateral typically. It does unilateral, and it's going to be within concurrent ongoing infection, right? Here it's more localized, right? Here it says it's septic arthritis, but it's a localized, maybe like she fell, she had some kind of thing, she's immunosuppressed, which you would assume with rheumatoid arthritis, and some kind of even a minor skin lesion could have spread the Staph aureus to her skin or to her joint.
Okay, I have to go over that because this was just a guess. Okay.
No, I just but talk it through, guys. Like when I do that, it's 90% of it is not me knowing it, and then as I'm
Mm.
saying it, I'm like, oh, okay, so this is there somewhere in the hippocampal region. It's being regurgitated as I'm forced to talk it. So jump in at any point if you need clarification or if you want to talk about something, talk it through. I have no problems with that. It's not like I have anything better to do. I learned from you guys. So, okay, next one. Oh, Lord, X-ray.
Oh my God, I'm sorry.
You're good.
I forgot.
Good
to-
job. Okay. So what do we got? What's the diagnosis, guys?
Is this
I
the
had tendinitis.
Yeah.
same?
Yeah, I was like, what the heck? This X-ray is not even gonna show me all some of
All
the
right. Like you're just gonna show me an X-ray and you're gonna be like, what's the problem? Like it looks like a joint. I don't know what to tell you.
I don't know. I didn't see anything wrong, but I wasn't sure. I'm not really good with X-rays, so
Yeah, like I honestly looked at it and I was like, I don't know what I'm looking at specifically. So I just went for the most common
yeah, I
in
know that's
NBMEs and UWorld
Mhm.
Yeah, I
tendonitis,
was like,
rotator cuff.
yeah. I think it was just the repetitive like motions of what he was doing was the
Mhm.
painting of the house.
The house.
So, like,
Mhm.
thinking, I was
Yeah.
like, okay, it's tendinitis.
What's the most common sits muscle affected?
Super spinatus.
Perfect. What's the test for it?
Mm.
Is it the empty cup? No.
Empty cup, empty
Empty
can.
can.
Yeah.
Yeah.
Which one of those things? You're emptying out some kind of structure.
What is that? I don't even know what that is.
What, the empty cans test?
Yeah.
Yeah, it's just like,
Oh, you literally rotate and then you
Oh.
press
yeah,
down on the
this,
arm and it'll hurt the back right there, the
Oh.
supraspinatus.
You know, you just study it. I didn't even know what that was. Okay.
All right, let's do this. Oh Lord, Lord, oh
There
Lord.
you go.
I already know what this is. Just give me the polling. Okay.
Yeah. She said, I'm ready. Put me in, coach. Put me in.
Watch me get this wrong. I'll be so sad.
Right? Having studied it for so long, and it's just like they're like, oh, technically you want to pain manage first, or like do this, or like do something else. Like,
I was like, ugh. I'm not in your head. Whoever the test makers are.
so which is the most appropriate, like short-term treatment for gout? Like an acute presentation of it.
Mm-hmm.
That's what they ask in here.
Okay. Let's see.
I love that they just threw in a Heberty node just because they were like feeling it.
I feel like they just need fillers. That's what they did. I was like, you already gave us the image.
Yeah,
It's already done.
it's messed up. Okay. So what do you guys use for someone who comes in, like let's say to the ED and they look like this? Like what medication would you give after you tap their joint and it comes back looking like a
I would
bifringent needle?
honestly start with an NSAID,
Yeah.
Perfect.
but since there was no NSAID, they almost caught me with the acetaminophen, but that's NSAID.
I got with
Okay,
that
so
one.
why do we not use acetaminophen? That's the real question.
I have no clue.
Well, it helps with the pain, but it doesn't help with the inflammation with the actual.
Mm,
No,
no, acetaminophen's bad.
for people with gout.
Yeah, for people with gout.
Really?
Yeah. So NSAIDs, right? Especially certain NSAIDs are excreted by the URAT system, which is the uric acid exchange system.
Mhm.
So one of the medications that can be affected that you can give that would make their condition maybe worse, I think, is acetaminophen. Because it gets excreted using the URAT, and that leads to problematic. Yeah, they didn't put it here, but one of the NSAIDs that you don't use, I believe, is that can exacerbate it is one of these. Like it's acetaminophen, or like it's a particular one of this particular type of NSAIDs that
Wait, but
competes with uric
acetaminophen,
acid.
acetaminophen's not an NSAID though.
I
Right?
thought that was the reason. Like acetaminophen is like one of those things that it could help with pain. It's like a pain med, but it doesn't help with inflammation. That's why it's not
Yeah.
considered like an NSAID. So that's
Yeah.
why I chose it. But so how does acetaminophen in terms of like using like the uric whatever cycle affects it? Does it just potentiate like increased uric acid, or
It competes with it. Like certain things, like for example, like lactic acid competes with a gout, right? For example, like the reason why alcoholics get gout, and it isn't just because of the breakdown of purines, right? That creates urea. It also is due to the fact that lactic acid that's made during drinking or after you've done your drinking, that has to be excreted somehow. And that competes with the same transporter as the as uric acid to be excreted renally. So that's why there's like a two double whammy when it comes to this. But I'm trying to look up which med contraindicated for gout. I want to double check. I want to make sure I get this right, so I don't.
Yeah, when I was answering this, I was looking for NSAIDs first.
Mhm.
I didn't really see an NSAID, so then I remembered studying like NSAIDs first line, second line colchicine, third line. Was it steroids?
I thought it was steroids was the second option, and then after that it was colchicine, for what I remember. Unless that's a different one.
And so, let me check. Or maybe it's colchicine and glucocorticoids are the second line.
Maybe.
And then because I know you can give allopurinol at some point. I think that's
Allopurinol
No,
is
you can't give
given.
allopurinol. It's
You can't.
contraindicated. Yeah.
Oh, it
Yeah,
makes it
so-
worse.
Yeah. So the thing with the allopurinol is it's not gonna provide it's not gonna relieve it right away, right? Allopurinol works long term, so it's usually used prophylactically.
Yeah.
Colchicine is used acutely.
Mm,
Glucocorticoids is only used if it's not responding to anything. That's like your last line.
Okay. Sorry, I gotta find this because I remember studying this.
You're good.
my brain hurts. I don't like.
This is a hard NBME, I'm not gonna lie.
I'm trying to figure out. Yeah.
but you guys are doing
Oh.
all right.
Okay. Oh,
Okay, let me just check another. I don't want to delay you guys. I just remember writing it down, so yeah, let's move on.
hmm.
You guys punch in?
Did you do the polling?
Oh.
Yeah.
My bad. I was like, you guys already punched it in. I don't know.
Mhm. Hmm.
Um,
Okay. Let's see.
Hmm.
Bianca, take it away.
Okay, so we're looking for the appropriate recommendation for antibiotic prophylaxis prior to the scheduled dental procedure. So we have an asymptomatic 47-year-old woman coming into the physician for a routine exam, hypertension, hypothyroidism during childhood, had a heart murmur, current medications, lisinopril, hydrochlorothiazide, and levothyroxine. No smoking, no drinking alcohol. That's her weight, her BMI, her pulse is fine, blood pressure is fine. Oral exam shows dark cracked right lower molar with swelling, erythema, and tenderness on the gums. Clear lungs, cardiac shows normal S1, S2 sounds with variation in S2 on respiration. Scheduled for a root canal next week. So what I put A based on experience. I honestly don't know because I thought you would give it just in case, like you can give them
Yeah.
prophylaxis for any because it's a root canal. Like you don't want them to get infected or anything like that.
okay. What type of
Correct.
varicose V though? Because I think that's where I obviously picked AE, but I was thinking because of the patient, I was thinking maybe the patient had a VSD, and usually, I don't know. I wasn't thinking VSDs could kind of be normal. So that's why I was like, would you
I
need to get
honestly don't even know. I thought it was just like if you need to make sure there's no infection.
right? Which
Also,
I do agree. But then I also was like, I know like if you had like a valve, I mean, I guess. So if you had like a valve issue, like a prosthetic valve or something like that, or some type of endocarditis in the past. So
oh,
that's
that's the reason for the prophylaxis?
yeah,
Yeah.
there's like certain
So
criteria. Go ahead.
So according to the American Heart Association, it's only given for those with prosthetic heart valves, prosthetic implants, previous history of endocarditis, unrepaired cyanotic congenital heart defects, repaired congenital heart defects with residual shunting or regurgitation, having a prosthetic device, a transplanted heart with structurally abnormal valves, non-cyanotic heart defects such as ventral septal defects, especially if resolved, do not require antibiotic prophylaxis unless another indication is present. When indicated, the antibiotic covers oral flora, should be administered 30 to 60 minutes before the time of the procedure as a single dose. So that was a lot.
Okay.
Yeah, it's a single dose.
So if you have
I
a
don't,
heart murmur,
So I had the actual prophylaxis thing correct. It's just that this person did not have any heart structural issues.
correct,
Right,
right?
okay.
She's generally in good health. Like she has just a variation of S2 on respiration. A variation on respiration of S2 is normal.
Oh,
Yeah.
mm,
Because remember, S2 is the pulmonic and the aortic valve closing, right? When you take an inspiration in, you're actually increasing the negative thoracic pressures. So more blood comes in, the preload increases. And if more preload increases, S2, that means more blood has to pass through the pulmonic valve. So that's why S2 changes, right? There's a splitting, there's a change.
you mentioned something as you were reading that long list. You said something about congenital heart defects, though.
Yeah, congenital heart defects that aren't fully repaired.
So if
Okay.
it was
Oh.
repaired, then you wouldn't need the prophylaxis.
Yeah,
So since she had like a murmur in childhood, it kind of resolved itself. So she
correct.
basically did not need any prophylaxis.
Yeah.
Mhm.
Okay. Dang, I didn't give you.
That's a very tough guideline because honestly, historically, I would have put A as the right answer, which is also, by the way, I got this question wrong. I put
Mhm.
A right now, and the answer said the best is E because they don't have any history of it.
Mhm.
Okay.
I didn't remember everything, but I did remember some type of prosthetic valve or something.
Absolutely. Let's do this one.
Mm.
Okay, Yui, it's your question. Take it away.
Okay, so 48-year-old man had 6 months history of pain in both buttocks when he walks and ED. He's been a smoker for 20 years. Blood pressure is of the extremities is less than half of that in his arms. His serum cholesterol is 286. What's the diagnosis? I wasn't really sure, but I picked A. At first, I was like, wait. And my first thought was aortic dissection, but I think that's more acute, and you would have like chest pain. But then I thought radiating to the back, so I said no, that's acute. I wasn't really sure though. Yeah, I wasn't sure though. So
Okay, work it through with us because I don't want you to like. Why would it not be aortic aneurysm? Like, think about what's happening. Pathophys. If it helps explaining it, go for it. I have no problem.
If I was thinking like aortic aneurysm, I would expect they would put something like bruit was felt or heard in the abdomen or wherever like the aneurysm is. And that will like lure me towards it.
is that more acute though, or Or not?
That one is not acute though. That one is, it could keep growing until
Mm.
you actually, um,
Dissects
Yeah.
or, just stabilizes.
mhm, mhm.
But the thing is, I understand what you're saying, Bianca, and that's fair. But I also think with atherosclerotic narrowing of the aorta, you could get a Brewy with that too. Because
Yeah.
Brewy is
Yeah,
just when,
it's just turbulence, right?
yeah, it's turbulence at the end of the day, right?
Mhm.
So I necessarily wouldn't pinpoint this. An aneurysm by itself would cause, especially at the abdominal level, wouldn't cause too many issues other than maybe minor back pain or like a little bit of like walking insufficiency. Like the blood has a hard time moving towards your lower extremities, right? So a little bit of that, but it's never going to be like as severe as what he's presenting with. So
Would you also feel like a palpable mass? with
yeah, you
any-
could with hella deep palpation, you
Yeah.
would feel a palpable mass, but
Okay.
most of the time, if it's a patient who is predisposed to like let's say like an aortic aneurysm,
Mhm.
most of the times their body habitus wouldn't allow you to like assess for an aortic aneurysm, right? Like deep palpation, like you can only go as deep as the
Yeah.
body habitus will tell you, right?
Mhm.
So I personally ruled it out by process of elimination. I didn't think it's a dissection because like, dissection would drop the blood pressure, right? You're hemorrhaging out, whether it's up when the thoracic or the abdominal level. So he's not having that. He's just having pressure changes, right? From the
Mhm.
upper extremity to lower extremity. That coupled with the fact that his cholesterol is so high and he has ED, it's likely we're thinking of something that's more associated with atherosclerosis, right?
Mhm.
So that's why the answer for this is C. Why would it not be D, coarctation of the aorta?
I would see like the upper extremities having a difference in blood pressure readings, not just like the lower extremities.
Yeah. And one of the best ways to see that is like your right hand to your left hand, like it would be a huge difference in terms of blood pressure. Especially coarctation can happen both in adults and children, but most of the times peds tends to focus on that rather than adults. Coarctation typically happens post-ductal in adults, right? So
Mhm.
after the ductus, patent ductus, right? Like, or the ductus venosus or whatever. Thromboangiitis obliterans or Buerger's disease, that's associated with smoking, right? That's the
Mhm.
one where if they stop smoking, they get technically better. I don't think they get better, to be honest. Like most of the cases that's seen in the United States, they didn't recover from it. It's like your limbs are falling out. So that's a pulseless disease. So it wouldn't be a change in blood pressure.
Mhm.
Okay.
Sorry, I had a question.
Yeah.
So you said the coarctation, you have a right hand to left hand BP difference. I thought you would also have the brachiofemoral delay. So I don't understand the difference. Or maybe I'm confused with what the question stem was saying. Like the blood pressure in the lower extremities is less than half of that in the arms. Isn't that
So
also like a delay? Or am I
that
confused?
is a delay. You're absolutely
Yeah.
correct. But the thing is that it's a equal delay, right? Like so the upper extremities are being perfused just fine, but the lower extremities are being perfused later. So the difference is if you have, let's say with coarctation, the right would get perfused quickly because there's no coarctation to stop it, whereas the left would have a change in blood pressure. And then you would also have a delayed femoral pulse.
Mhm.
So it's like it adds one more thing to your workup or like your physical diagnostics to confirm it.
Okay, so with the coarctation, you would have the right hand to left hand BP difference,
Mhm.
Yeah.
whereas
That's
the what were we talking about? The aortic is it the aortic dissection we're talking about that has
just
that?
atherosclerosis of the distal aorta. Like we were just talking about that answer versus coarctation, right? That we would
Yeah.
see is like changes.
Mm-hmm. Okay. Okay, thank you.
No problem. Let's do the next one. Okay, guys, what's the answer?
Tamponade.
Is it tamponade?
I said pericarditis.
Yes.
Pericardia. Yeah.
So it's pericarditis.
Always mix these. So
No
that you would
worries.
have the JVD. Hold on.
Mhm.
Mm-hmm.
JVD, the hypotension,
Mm-hmm.
and the heart sounds are distant.
Yeah, that's Beck's triad. You're not wrong. You're
Mhm.
absolutely right.
Yeah, for cardiac tamponade. Or am I wrong?
Cardiac tamponade is a term that's reserved typically for when there's like some kind of fluid level changes to the pericardium, right?
Mhm.
Like it's between the pericardium and the heart, like there's some kind of fluid buildup, distant heart sounds, all of those things. Here, I think the thing that they're focusing in on isn't the fact that he has all he has that precipitated this was just chemotherapy, right?
Oh, I just see it. The constrictive.
Yeah.
Mhm.
So it's like a constrictive pericarditis. It changes our understanding of this. It's not like a true Beck's triad, right? Like Beck's triad for us is like very like focused in on the fact that like there's some kind of trauma, some kind of like
Yeah, yeah.
change. But this is like a version of cardiac tamponade, but it's due to the chemotherapy.
Mhm.
Cool.
Okay.
Next one.
Oh.
Here it comes. Is this the same one? Yeah, same question. So we can see the EKG. Where do they find these EKGs? That's all I want to ask. Like,
On Google. Actually, not even Google. Google has better images.
I know.
Is there any way you can enlarge the EKG? Or like, yes, thank you.
You guys are wondering, you don't need to count out too many boxes or go through the calculations of it. The QRS complexes are tiny for a reason.
Yeah, I know this. What's the answer, Troy? Sorry, zoom out. Thank you. Okay.
The answer, young doctors.
Mhm.
Okay, let's see. Bianca, take it away.
Okay. So which of the following is the most likely explanation of the findings? So their presentation does show some type of either cardiac tamponade or some pericarditis that's leading to, like, if you look at the EKG, yeah, you have like really small QRS complexes, but also you also have pulsus alternans on there. So I felt like it was like it's kind of like the same question that we had before. So I just put pericardial effusion for this one, like just like a fluid overload or something like that.
Mhm.
Does that make sense? Should we talk about why
Yeah,
it's not?
the only thing is that wouldn't you also, I guess you may not see it, but the ST elevations, or am I confusing with something else? Oh, am I thinking, right?
Oh, that's
So
for pericard. If you're looking for diffuse ST elevations, those ones are for
PEs.
pericarditis, like acute
Oh,
pericarditis. But this one's
Oh,
not.
you're saying pericard. Oh, so what are you saying? You're saying
This one is, it's kind of like the same thing as like the cardiac tamponade with the like pericardial effusion. They're kind of like have like the same presentation,
mhm.
because if you look at the EKG, the reason why the QRS complexes are so small is because it's so far away from the heart that it's not really able to pick up that really high amplitude that the heart is having. So with cor pulmonale, that one is more of like fluid backed up to the lungs, so you won't really see that on the EKG reading.
Okay.
Yeah.
I think I just honestly I didn't know what I was looking for the EKG, but just based off the stem, wouldn't it be pulmonale too? Because the patient has COPD, and now they're showing signs of like heart failure.
true, but like they
Yeah,
have
you're
a
right.
distant heart sound, they
Mhm.
have a hepatomegaly. Hepatomegaly, if it's just localized, it's basically something constricting the heart that's backing everything up, right? Cor pulmonale, yes, would present with hepatomegaly and all these
Mhm.
things, but
Mhm.
cor pulmonale tends to be like a very like exaggerated thing. Like it would present with like, if it's been prolonged, it would actually present with right ventricular hypertrophy, because the pressures of the lungs have to be overcome by the right heart in order to pump blood. So maybe you could even see a right bundle branch block, but you typically won't see low QRS complexes and changes
And
that are so minute compared to a regular EKG.
and they even said the lungs were clear, so I just took out cor pulmonale from it.
What's the finding for pulmonary embolism in an EKG?
Mm,
Divine talked about it. It's
I
important.
know, I know. I haven't gone back to it. Okay.
Something called S1.
Oh, please, S1, Q3, T3.
Yes, there we go.
I thought that was like one of the subtypes or rarity ones, but the
Yeah.
most common thing you would see is,
Tachycardia.
yes, there we go, sinus tachycardia.
Yeah, exactly. Because they're not going to give you an EKG and ask you to diagnose necessarily for a PE, but if they do, then you guys know S1, Q3, T3.
Okay.
All right, let's do the next one. I'm gonna let you guys go at like 25.
Okay.
Okay.
I don't want to be mean and make you guys stay till 40. That'd be messed up. All right, guys, what's the diagnosis?
I put E, thoracic aortic dissection. I think mainly because the pain is radiating to the back.
Yeah.
And then it showed like the difference in pulses, right arm and left arm.
Mm-hmm.
And it's so funny because we actually had that on the floors.
An aortic dissection.
Yeah, a potential aortic dissection. So everyone was like on high alert for this patient. But
Mm-hmm.
I don't even know what happened with the patient. He looked so fine. He just wanted to walk out, and I was like, oh my goodness. His
Good
blood
Lord.
pressures were different in each arm. We were like trying to figure out why is he still standing.
Yeah.
I have a question really quickly. So remember how back to the other question we were talking about the coarctation of the aorta,
Mhm.
the right hand to the left hand, the BP difference. So that's the same thing with the aortic dissection too. I think maybe I should have gone into more detail when I was studying because I know there was a difference in BP, but I thought it was. Oh, maybe I did know that actually. I think I'm just confusing them all now. Like the difference between the difference between the BP in the upper extremities versus the lower extremities, and then the difference in BP between your left arm and right arm.
Yeah. So let's just go through it really quickly and keep it all like structured. Okay. So let's start with coarctation, right? There's two types: preductal, postductal. Preductal, children; postductal, adults. Preductal doesn't matter, right? Like all it tells you is that it's a coarctation, it's a narrowing of the aorta, typically the ascending aorta as it's about to descend downwards. So it causes a pulse difference from the right to left, and it causes a femoral pulse delay. It's not absent, but it tends to be delayed. Now, if you have an aortic dissection, depending on where it is, because remember, there's Stanford class A and A1 and A2 and then B. So like, depending on where it's located, it's going to present a little different, right? Most of the times, if it's upper, right, Stanford class A, that means it's either close to the heart or it's in the ascending descending portion, right? That can cause typically blood pressure changes, right? From the right to left, possibly, depending on how extensive it is. If it's A and it causes aortic regurg, then you're going to have presentations of aortic regurg, right? Because it causes the aortic root dilatation and causes that. Now, what's the other one we were talking about? We were talking about atherosclerosis. Atherosclerosis will cause more of your other presentations, such as like your pulses are different in the lower extremities. Like your blood pressure is not as high, but it's a little bit lower. But the difference is that it would also cause you, typically in older males, to have erectile dysfunction, right? That's just because of the atherosclerosis. So like the etiology, like let's say like if it's an abdominal aortic aneurysm or like an aortic dissection, that wouldn't necessarily cause an ED.
Mhm.
By itself, it wouldn't cause ED, but if it tends to happen concurrently, most of the times people come with it both, because if they have an aortic problem, then they typically have a poor lifestyle, fast foods, smoking, everything that causes it, then that would affect the ED as well.
Okay.
So that's my thought process of like working through the differentials with that, if that helps.
Yeah, it does.
Okay.
Yes.
No problem. Let's do the next one. Okay. Treatment.
Warfarin. No,
Warfarin.
yeah.
Okay. Awesome. Just in case, they ask it another way, what does it inhibit?
Warfarin?
Yeah.
KOR.
Yeah.
Yep. Vitamin K, epoxy, whatever, something. So if it's fully spelled out, that's what it is like. Why can't we give aspirin? I mean, it's an antiplatelet, anticoagulant. It tends to prevent heart stuff. Why can't we give it for, I don't know, other
I
stuff?
thought it was the Child Boss score in my head. That's what I went through.
Yeah.
Yeah, so I just did that score, and then I was like, okay, this woman basically meets the criteria for warfarin therapy, so I just put warfarin.
So what is that score again? Because honestly, maybe I shouldn't have thought of it that way, but I always remembered if you had some type of
I don't know if that's the right way to tackle this question. I was stuck between A and D, and I was like, wait, can the score help me? And I used it. But the CHOD VOS score, I think is like what is it? Congestive heart failure, hypertension, age greater than 75, diabetes mellitus. I don't know if it's like some vascular like stroke or something like that. A is age between 65 through 74. And then SC is basically the sex, so female has a point.
Perfect.
what's
You're crushing it over there.
what's the-
So
Hmm?
what's C?
you said, wait,
Chad Bosk. So
oh, I
are
thought
you
that was a
talking about the
CFA.
last C? Which one?
How do you spell this, Chad?
It's CHADVAS, and then the C is small because it's right next to the S.
Oh, okay.
What
Okay.
is the Chad VAS score used for?
So basically to see what type of medication to give after, is it an MI or post-stroke or something like that? I don't. I don't remember.
It's used for atrial fibrillation. So
Oh,
if they have a history of
okay.
AFib, they use Chad VAS.
Oh yeah, I forgot.
Yeah.
I
So
just
basically,
when I see those options, I was like, okay, I'm just gonna do the Chad Boss score.
yeah.
Don't know what it's used for. Okay.
No, but how would you score it? Because I keep forgetting this.
Okay, let me show you.
Anything- Oh yeah. Anything
I'll-
between
I'll-
0 to 1.
I'll
I
make your life a little easier here.
think.
So when to use, right? 1 year risk of thromboembolic events in non-coagulated patients with AFib,
Yeah,
right?
there you go.
So how we do it is, how old is this patient? 67. So she's in 1-point scale. She's a
Mhm.
female. That's another point. She has a history of congestive heart failure.
I don't think so.
So we're gonna go yes. Hypertension, let's see. Doesn't show, so we don't know. Okay, so she's had a prior history of strokes and whatever. So that's there. Vascular disease, yes.
Mhm.
Diabetes history, yes. So based off of that, she has a 7 point. So that means she's at a moderate high risk. So
Mhm.
based off of that, what's the next step? Anticoagulants is not recommended when patients with 0 to 1, depending on if for those, okay. For those patients with whom is concerned, risk of bleeding, okay. So anticoagulant should be started with patients with greater than 2 if male or greater than 3 if female, right?
Yeah.
And then this is the key thing. This is why we stopped doing this. So
Okay.
aspirin monotherapy is not supported for current evidence. You know why? Because aspirin alone doesn't work in the long run. Aspirin has a lot of positive effects for the heart
Mm-hmm.
because of the antiplatelet
Oh.
component of it, but we're talking about a big ass vessel, and that big ass vessel needs the big guns. Warfarin, we don't give warfarin to everyone willy-nilly, right? The preferred method is either you use warfarin, or if you have it, you use apixaban.
Yeah.
Okay. Does that help, by the way?
Yeah, it does. I think I just need to finally know this. It's so unfortunate though, because I feel like when we get clinically, we just pull it up on our phones on how to.
Yeah.
I have the app.
Yeah,
But
I mean,
yeah, I just
MedCalc
didn't know.
makes your life easier. So this is something that helps. All you have to remember for a female, if it's greater than 2, you're starting them. Any one of these, if it's positive, you start anticoagulants, right?
Yeah,
So if it's
for sure.
plus
But you
2,
know, okay, so which ones are the +2 if they're the age 75 and
they had a prior history of,
stroke?
yeah.
Okay, and then everything else is plus. Okay.
Ooh, what's happening here?
Ew, what is?
Let's restart the poll. Lego. All right. All of us is punched in. What's the answer? You want to take this away?
Oh, yeah. So 1 week after undergoing this surgery, appendectomy, a healthy 61-year-old man is out because of fever, chills, cough, and mild shortness of breath. During the procedure, a peritoneal drain was placed. Postoperatively, IV Cipro and metronidazole was begun. And then he had persistent LAS that was diagnosed on day 2 post-op, and then a nasal gastric tube was inserted. So yesterday, the NG tube was removed and was advanced to a regular diet. Today, his temperature is 100.6, pulse 110, respiration is 22, BP 110/60, oxygen 94, crackles are heard at the mid-left lung base. Abdominal exam shows a clean, dry surgical incision. The drain is mostly clear fluid. Luke count is 15,000, and chest X-rays are shown. So I thought he was had some type of aspiration pneumonia.
Mhm.
So usually even though Marita would probably say differently. Well, I don't know, but I think you would want something to cover any type of, you want something to cover gram negatives, gram positives too. And also the fact that he was recently in the hospital, you also want to cover for MRSA. That's what I was thinking.
Mhm.
I'm not too sure on my answer. I did pick, wait, what did I pick? I think I picked
You pick.
C.
Yeah, you pick C.
Okay.
You pick
Okay,
C.
yeah. So that's what I was thinking, but I wasn't super sure.
And that's the right answer
Yeah,
because this is broad spec, right? It covers your gram negatives and your gram positives, and that's
Mhm.
great.
And I
Um,
protect the MRSA as well, because he was like, what is it? He was discharged from the hospital, right? I think,
yeah.
Yeah.
oh, he is discharged?
Wait,
No. He's still at the hospital. Only thing
Oh,
is they
okay.
just need to do the next step to kind of
Yeah,
manage him.
like to cover like
Yeah.
everything, yeah. So I was thinking like it was MRSA or Pseudomonas for him.
And most
okay.
of the times it tends to be Pseudomonas in the hospital,
Mhm.
and that's the best you can do, right?
Mhm.
Like you cover with ceftazidime, and that's good enough. That's the third generation. I think that covers most of it. Gram
Yeah, I
negatives
just
and gram
wasn't sure. I
positives.
forgot if azithromycin, do you guys remember? Like, can it cover? I don't think it can cover MRSA.
MRSA?
For MRSA,
According to Maritato, yes, but don't learn it for that.
Yeah.
Okay, that's all I'm gonna say.
I was like, it's Vanco, Dapto,
Yeah.
Lanizid, something else.
Yeah, but those are the preferred ones. Like most of the times they ask about Banco
Mhm.
and your Cip, not your Cipros. I'm talking about your broad spectrum coverage, but that aren't fully broad spectrum. Like ceftriaxone would cover most of it. Like
Yeah, it doesn't cover MRSA. And azithromycin doesn't cover Pseudomonas.
No, that would be your fluoroquinolones that you would give mainly for those.
Okay,
yeah,
before cover.
Yeah.
Oh,
Or your third generation. That's the only third generation that's able to cover for Pseudomonas.
mhm.
ceftazidime, yeah.
Yeah, there's a fourth generation. I forgot the name of it, but
Yeah.
that one, yeah.
That one. But that one, the what is it? The fourth and the fifth are the ones that are like broad spec technically.
Yes.
And I think the last one covers MRSA.
Yeah, that
actually.
one covers MRSA.
Yeah, ceftazidime.
Yeah.
Okay, let's look at it. Cool. Let's see. What's causing this guy's lungs to collapse? So the x-ray shows that his right lower lobe is collapsed. So we were between A and E. Now we can get rid of certain things, right? We can get rid of the pulmonary vascular obstruction. No, that's a PE.
Mhm.
Proximal airway inflammation, what is that?
I'm not sure what that was.
I thought it was what's it called? Freaking like it's not asthma. Um Proximal airway.
Some type of trachea inflammation or something.
I mean, it's just bronchitis. Bronchitis that's due to his
Yeah.
smoking. Like that
Yeah.
wouldn't okay.
Chronic bronchitis.
So the thing with smokers is that their lungs won't collapse. If anything, it will hyperinflate, right?
Mhm,
Because you're
mhm,
destroying the pulmonary parenchyma, leading
mhm.
to kind of the hyperinflation, right? Um, he doesn't have a hyperinflation. He
No.
has the opposite. It's
Yeah.
collapsed, right? And they think there's a mass. So when you've been smoking for 50 years, you'd like to think malignancy. What's the most common malignancy with smoking?
Squamous.
Squamous, right? And if there's a mass, it can eventually collapse, whatever, because the alveoli are tiny. They don't have much strength, right? So the answer here is A. That's how I worked through to get to A. I don't know if that's the right way, but that's the way I worked through it. Increased pulmonary capillary wedge pressure. What does that tell you? It's something wrong with the left heart, right?
Mhm.
That's not what's happening here. Pleural inflammation with fluid formation. Pleura is talking about outside, right? It's not just talking about just one area. It's talking about a lot of different areas because it's the pleural cavity. That's not what's happening here. Proximal airway, like we talked about, pulmonary parenchymal necrosis. What is the necrosis coming from?
Honestly, I picked that. I wasn't too sure. But at
Mhm.
first, honestly, I guess I should observe it more. I was thinking would it be some type of TB, but I didn't really think of this smoking and the mask. But then I didn't really know what that meant anyway, the parenchymal necrosis, and I didn't want to waste time, so I just clicked.
Gotcha.
I wasn't
No
sure.
worries. So it wouldn't pulmonary parenchymal necrosis. Necrosis typically happens usually one of two things or one of three things. Some kind of lack of access to the nutrients that the cell needs to stay alive, either through blood or through some other means, right? It's being starved of oxygen.
Mhm.
So one of those two ways it's going to do that. Or it can lead to cause from infection. But we don't think he has an infection here. He has hemoptysis, non-productive cough, and he has weight loss, guys. So those are all like the buzzwords for malignancy. So based off of that, we get rid of necrosis. We go with something more problematic, which is a tumor. So
So
we get
wait,
rid of
for
that.
TB, what are you looking for, like an infection? So like the fever?
Yeah, fever,
Yeah.
night
But
sweats, those things
so
with TB.
because like TB is more chronic, so you would have a fever for like, let's say 4 weeks or something.
Yeah. And sometimes they present with fever, sometimes they don't even have a fever. And the crazy thing is that in NBMEs, yes, they have a fever, they have hemoptysis. They do have a productive cough, right? Like they cough up blood. TB is TB, right?
I don't
Um,
think they come with a collapsed lung though. TB is more of
yeah,
like a granuloma just literally in the lung. I don't think it causes like a collapsed lung.
yeah. It doesn't cause atelectasis. Typically, two things that'll cause atelectasis. You're either pushing against your lungs, either with air or a mass, or it just spontaneously collapses, or trauma. But technically with trauma, you get air in your lungs. So
Mm-hmm.
that whole pathway. Okay, let's do this one. Getting close to the finish line. Okay. See how we did. Torn between two. No problem. So let's, before we make a diagnosis, right? What what type of patterning do you see here? Restrictive or obstructive?
Obstructive.
Obstructive. So by that definition, we can get rid of ankylosing spondylitis, cystic fibrosis, extrathoracic airway obstruction, idiopathic pulmonary fibrosis. Those are all gone.
Mhm,
That leaves us with two things, two obstructive patterning, asthma or emphysema.
mhm.
So what would work? Why is it not emphysema?
I think it, for me, was the wheezing.
Yeah, emphysema is what's really going on with emphysema?
You have destruction of the alveolar.
Yeah. So the thing is when it's destroyed, it's gone forever, and they would have like minimal response to anything, right? But here they didn't give you that much information. So according to them, you're supposed to come to the diagnosis of asthma based off of like just purely just how it's like looking in the graph. So in the graph, it would show a irreversible obstructive patterning with a flow volume loops, right? Like here it's showing that there's a partial preservation with the flow volume loop. Do you guys see that?
Mhm, mhm.
So that's the reason why it's more asthma as compared to
I would have to read up on
emphysema.
it. I never knew I always struggle with the difference, but I didn't know how to do with the flow thing. So I can just read it. I don't want to take you guys' time.
Wait, could you explain the that thing again? So the bottom loop is for what?
The bottom loop is, I think, expiration. So let me see if I can pull up a flow volume loop.
Because I have like the obstructive and restrictive like volume loops in my head.
Yeah.
Yeah.
So I'm like trying to figure out like how could you vary asthma and emphysema from, because they're basically the same as like obstructive, right?
Mm-hmm.
So how would you use that in order to figure out, oh, like this is asthma or emphysema? Because I would say like if they were to say, for example, they gave like some type of bronchodilator and the asthma and the whole thing resolved, it went back to normal, I would say it's asthma.
Yeah.
But they didn't give
But
us that
they
information.
didn't give you that information. True.
Yeah, so I
So
just
let's,
literally went on a whim. I was like, he doesn't have, like, if it was for emphysema, maybe the antitrypsin, was it the alpha-1 antitrypsin one? That would be. Oh,
Yeah, hold on, let me see.
okay.
Just never seen that before.
That's emphysema. Ah, so.
so his inspiratory capacity is preserved to a certain degree.
So is there one that shows both asthma and emphysema in one? Can we find one?
Oh, Merck manual. I used that before. They really did make us like learn this like a pulmonologist. That's messed up.
Right. Peds, NICU was the scariest thing of my life.
Oh, where is it?
Why am I looking?
I'm trying to find one that like captures it to a
Yeah.
good degree.
Hmm.
When in doubt, Google Images. Let's do this.
Yes.
COPD asthma. Oh, we need something for emphysema. Can I try that?
Let's see what-
Mm,
Oh, there. I thought I saw one. Come on, Google.
okay, restrictive, obstructive.
Let's
Wait.
do this one.
As, oh, okay. Hmm,
The
I
flow
don't
loop
get
is a
it
little
because it
different.
kind of, yeah, it kind of looked, if we were to look at the diagram again on the question,
Yeah.
it looked like emphysema.
Mhm.
Correct.
So
Really.
how, yeah, it looks like emphysema. So how would we figure out? Because it's only like very acute that this is happening, like a 6 month, not acute, but chronic is 6 months history. But I feel like
Yeah.
someone with emphysema, um,
Yeah, I feel like what did you use to get to asthma besides the thing? You know what I mean?
right.
I I was stuck between the two.
Mhm.
I don't know.
I think for me, it was the wheezing, because like the
Yeah.
bilateral expiratory wheezing, that's like all we heard for patients that are with like an asthma, like attack or something like that, or they had like something asthma
That's what we
related.
saw on the floors all the time.
Mhm.
It's annoying, but like I don't see how emphysema would present similar to asthma.
Right. Then that's what I was saying, because like even COPD also
Yeah.
had wheezing.
Correct.
So I was like, but COPD and has the combination.
Yeah.
It's,
We have to circle back on this question. I
yeah,
have to dig some more.
The only thing I was thinking is like maybe because he's a little younger and he smoked relatively for just 5 years.
A short period of time. Yeah,
That was
5 years
like,
is not bad.
yeah, so I'm okay, maybe I don't think you're gonna have much damage. I mean, probably will, not as much as like,
and that's
Yeah.
what weaned me off from emphysema. However, it still didn't make any sense. Because even when
The
we look
flow
up
pattern.
the pattern, yeah, it looks more emphysema, not asthma, unless those little circles or whatever are the actual like changes that happens. I remember that it measures like the like at was it 70, 95, 75, something like that, 25.
mhm.
And then that shows the actual, I don't, I remember something like that. But
Peak expiratory flow.
yes,
Yeah.
I don't know if that's gonna be,
I don't know. I wouldn't be able to diagnose based off
yeah.
that, especially with the peak expiratory flow. That's a pulmonologist level thing.
Yeah.
That's all I'm gonna say.
I don't know
But
why they-
I will look into this though. That way it's easier so for us to understand.
Mhm, mhm.
Let's do the next one if that's okay
Yeah.
with you guys.
Yeah.
Okay, last but not least, what do we think this is?
Yeah, it was the foundry thing that his occupation.
Yeah,
Yeah.
that's
I don't
all I
know.
used. I was like,
I
it's
was like-
silicosis. That's all I know. Foundry, that sounds
Yeah,
close
I don't
enough.
know. What is Foundry? What's a Foundry?
A foundry typically like breaks up like bits of like it's almost like mining, but like they typically just work with like big chunks of pre-cut pieces of rock essentially, and they will like cut it into the appropriate size for like granite countertops and all these other stuff. So like sometimes they even if they need limestones and other stuff, they'll do it. Like, but like most of the times they get it silicosis exposure.
Yeah, I was it stuck between silicosis and asbestosis, but I remember asbestosis, those ones have a lower lung thing because I just remember ceiling is lower lung.
Mm-hmm.
Aspergillus, no, because it doesn't look like he's having like any bacterial infection.
Yeah.
And then asthma, that would not show up, it will be normal. And then bronchiectasis,
And they did say you would see like, I remember silicosis, you would see like an eggshell calcification. Do you guys see that on the chest X-ray?
No.
no,
Eggshell, not here.
not, mm-mm.
Yeah.
I swear, these people are trying to make me mess up on the exam.
They
It's
didn't say anything on the explanation about the X-ray at all. I just want to make sure.
Let me check. For aspergillosis or which one?
the X-ray for like the silico.
Oh,
The
silicosis?
Yeah,
Oh, X-ray may show honeycombing, especially in the apices. The pulmonary function test discloses a restricted pattern of lung disease marked by a decreased overall volume and capacity, but a preserved FEV1 to FVC ratio. This ratio is key to distinguishing obstructive versus restrictive.
All right, so what is the normal? Because I always thought normal was less than 80%, but I think it's different.
I don't know,
normal
was
is
it,
not less than,
I thought, was it 70 or 80? I don't know.
I thought for obstructive is supposed to be less than 70, but people has been saying 80. So
Yeah, I think SGU taught us 80.
okay.
So I kind of always had that in my head, but now, so now I see 70, I'm like, wait, so is that normal? Or is that,
I
because I hate
all I
stuff.
know is like if I'm seeing a ratio very low, that's obstructive, and then if it's like borderline high to normal, that's restrictive.
So it's 70% according to workers and healthcare protection stuff. So,
Yeah, so it is 70.
Okay,
so a normal range is between 70 to 80 in adults, and it can drop as low as 65 for people older than 65.
I'm not gonna memorize that.
Yeah.
70 or 80 is fine.
Correct. But we did it, guys. That was 25 questions of pure hell.
Yeah, my head hurts. Okay.
Okay, get some rest. I'll stop the recording.